I think we're planning for the 24th of June. We're going to launch Selfie Your Smile. So we'll be in touch with everyone at Dentist Sports UK. No, Sports. So, yeah, anyway, you decide.
You'll get sports dentistry. You can say whatever you like, Serpil. We'll all listen, don't worry.
Welcome back to the Sports Dentistry Podcast. Umar, you made it home. You made it home from Tenerife.
Yeah, got back in one piece, 2 a.m. this morning. So a couple of hours kip, and then you're obviously on the blower early saying we need to get up and get stuff recorded, and you've got to do it. Take one for the team. So here I am.
Yeah, I feel so sorry for you after a week laying in the sun, having to get up, at a normal time during the week.
To be fair, we were up quite early every day while we were there because I was there with my cousin and his family. So we kind of got up and did a lot of family related things. Yeah, it was good fun. But I was also delighted to hear that the year is now 2025 and that you have internet Wi-Fi in your home.
Yes. It's been a challenge. I've had to get a bit of Starlink in to save the day. I'm still testing it out, but it's going to make it a whole lot easier to record these podcasts, being able to do it from home. No more interruptions from buskers out in the street in front of the clinic.
Yeah, it's a nice added extra to the podcast, that was.
Do you know what I was thinking there is when you were in Tenerife? And it was the first time I came across it was a few years ago when I was in Benidorm for my mate's 40th, was see whoever invented these wristbands that have the hotel you live in. It opens your door to the hotel room. It allows you to get your food and your drink in the hotel. Absolute genius. Like, they're the most handiest, easiest things to use. Whoever invented that.
It was, funny you should say that because we were on holiday and my daughter got one, right? So she gets one as well, but they get a different color. So kids obviously get a different color and they're not meant to open your door because there's obviously other doors that take you in and out of the resort. So it's not meant to open your door. So she was running to the room. She's like, "Can I open the door?" I was like, "No, it's not going to work. It's been programmed that you're not allowed to, if you're a certain age, you're not allowed to do it." She goes in, puts her wrist on the door opens. And me and my wife were like, that should not be happening because then she could potentially go to another part of the hotel and go to somewhere where she's not meant to go. She was so excited by that. She was so happy by that because obviously she's thinking she's got a little bit of independence. And my little niece, she's 9 years old. So they programmed her to allow her to do that. But she now thinks she's a big girl. My daughter's going to be 60, so you now think she's a big girl. She could do that. But it made her smile and it was all good. But yeah, like you said, I think it was fantastic.
Ingenious, definitely.
And also for you, when you get lost around the island.
Oh, yeah. It's the taxi home. It's the Uber home and the taxi home. And especially with my pronunciation, and I can't pronounce a lot of English words, never mind foreign words, hotels and stuff. You just have to show them the wristband. It's perfect.
Absolutely.
It's perfect. So we got quite a lot of positive feedback of Anthony's podcast. Really interesting podcast, and what a story he's had and his passion for what he does. Again, it's almost every guest we have on now that you can feel why they have got to where they have got to, and experiences that they have had is that passion that they've been able to drive themselves with.
Yeah, it was great to hear his story. And one of the takeaway things I got from there was he said he sent over 100 emails and he got one reply.
Yeah.
And that one reply basically changed the trajectory of his career. Now he's doing, thousands in a day, tens of thousands a month, hundreds of thousands a year in Mouthguards, but he's still not standing still. He is still looking to move forward. How can things get better? How can things get more sleeker? Honestly, in awe of what he's doing. And it was great to hear his journey and where he sees it going, and the fact the partnership he has at the moment with Prevent, with the IMGs is, I don't even know where the sky's the limit. The sky's the limit with what Mouthguards could potentially achieve.
Yeah, I like the way he innovates. He doesn't just, he thinks outside the box, and he looks at it from his own perspective and sees, is there ways he can improve? Is there ways he can do better? And the way he's been able to use that to develop the manufacturing process of the mouthguard, but also how He's at one stage set standards, a certain minimal standards for boil and bite mouthguards and things like that. So great story, very inspirational for people going out there. And as you said, he got that one reply out of them 100 odd emails, and that really changed everything for him.
And that's the thing about putting yourself out there. And we've said that so many times, and I think we're going to say it so many times. It's like, if you have something that you think may change the scope of dentistry in general or sports dentistry in general, what's the worst that can happen? You get a no, or you don't get, and nobody gets back to you. But there's maybe that one person or one organization that's willing to take that punt on you and see where that leads you to. The golden nugget I got from that podcast with him, we obviously had the conversation about mouth guards and the changing dentition, patients who are wearing orthodontic braces or aligners. And he talked about using the boiling water, putting on the fitting surface for 5 to 10 seconds. That softens it. Then you put it in your mouth and you have a cold drink of water, and that helps reset it into the new position. And you can do this every 2 to 3 weeks. And for me, that was actually quite an eye-opener, because I can now factor that into my treatment planning going forward. And like we said, you have done it differently. I have done it differently. Anthony's got his take on it. But that's what this podcast is about, is so we can share those informations to share the information to the listeners as well, so then they can incorporate that into their practice, because every day's a school day.
Yeah, definitely. And it's learning from each other and come together to try to make things improve. And I think that's an important thing. I think Fiona said it in her interview, it's important to leave the ego at the door and accept that there's other people doing things other ways, and looking at it from that perspective and seeing, can we improve, or are we happy with how we're doing things and stuff like that. But it's really not, it's my way or the highway. It's really having that open book and having these discussions and trying to find what's the best way we can support these athletes.
Yeah, you have to be willing to listen though, don't you? You have to be able to understand someone else's point of view. It doesn't necessarily mean that they're right or wrong, but even one little bit of information they can give you, you might incorporate that into the way that you work, which is fine, because there's more than one way to skin a cat. So I think you have to have that ability to listen, to understand, to digest the information and use it to what's best in your hands.
Definitely agree.
During last week, you sent me an Instagram clip of a very famous ex-footballer who goes by the name of Joey Barton, a controversial character. He talked about how having your teeth done, or for footballers who have had their teeth done, made them more prone to picking up injuries. So just talk me through what you took away from that rant.
The rant. First of all, Joey Barton's very entertaining, very controversial character. Definitely a massive Marmite character. He's either like him or like the majority of people. Maybe don't, maybe don't, but he's definitely entertainment. But yeah, it's definitely interesting, a rant. And I think what really struck it out to me was the fact that it was coming from an ex-footballer that maybe doesn't really have a lot of knowledge from a dental point of view or a medical point of view, but he's so strongly opinionated about how he's seen soccer players getting their teeth done and then increasing the injuries. And it's quite an entertaining rant. He goes on, it was actually started by Kevin De Bruyne, but he was giving advice to younger players. He was saying, if you get a few pounds, don't be going away and getting your teeth done. You're more likely to get injuries. And I think that's where sports dentistry has to come into aspect, because a lot of we see it when we're working for athletes, especially when they start to get better at what they do, and they're more in the spotlight, and they're maybe getting picked for their national team, and they're going through interviews, and they're, especially maybe more now with social media, they don't even need to get to that stage, and they're still very image conscious, and they're very self-conscious because they're promoting themselves on social media, and they're looking to improve their smile. And I think that's where sports dentistry comes in, because there's lots of cosmetic dentists out there. There's a lot of aesthetic dentists out there. And Joey Barton, he was making the rant about turkey teeth. There's a lot of people traveling abroad to get their dentistry done as well. But when they're getting it done, they're obviously focusing on improving their smile, and they're not looking at it from their athletic point of view. And it's an interest area of mine for the last 15 years, and it's really what brought me into sports dentistry was the influence of the lower jaw position on athletic performance. Done some good research in it as well, and there's definitely an influence there. And if that's not taken into account whenever we're changing their smile, if we're not taking into account the possibility of changing their occlusion and changing their lower jaw position, we could have that negative impact on their posture and increasing their risk to injuries and stuff as well. So I think it's probably a bigger issue whenever the lower teeth are being involved. It's possible to maybe do the top teeth and cosmetically improve the top teeth, whether that's through orthodontics like the likes of Invisalign or through veneers or composite bonding and whitening, maybe without interfering with their occlusion and keeping them in that sort of occlusion that they've always had when they were developing their skills as a sports person. But once we start changing their bite and changing their occlusion, then there is a chance that we can have a negative impact on them. And particularly when you look at occlusion as a subject that there's a lot of debate in, and as an occlusion that's possibly hard to teach as well, and maybe not taught very well at undergraduate level as well. We have to take that into account as well. And the biggest thing that I look at as well, from an easy point of view to have a look at occlusion, if you're looking at taking an occlusion for a sleep appliance, like an MAD, you're bringing generally the lower jaw forward to improve the airway, which you would think that would, if we were improving the airway, you focus on sleep there and sleep apnea and sleep disordered breathing. But it would also, from an athletic point of view, improving your airway, you would think would have a positive impact. But then a lot of the times, if you're looking at it from like a CR, if we're looking at reconstruction occlusion and the traditional way of using CR, a lot of the time that could lead to a retrusion of the lower jaw, which is completely opposite to what we're doing for a sleep appliance. So then, if we're feeling that a sleep appliance opens up the airway, are we then having a negative impact on the airway if we're restoring into CR? So that's a bigger conversation that we're going to have here in the podcast. But you can see how what really struck me about the Joey Barton rant was how the fact that it's got to Joey Barton, you know, it's completely outside our profession. It's outside the medical profession, and it's coming from an ex-player who is that passionate about his experiences, where he's seen players that have had their teeth done and now they're starting to get multiple injuries, or they're starting to get issues with injuries. And it's that sort of connection. The fact that he's seeing that connection was more what stuck out of me in that rant than anything else. So it's really interesting. Whether we agree with it or we don't agree with it, what it is doing is bringing eyes on sports dentistry, which is a positive thing for us, and where we can try to help raise awareness of the importance of sports dentistry and try to use that education to do what's best for our athletes. And as we know, like patients, every patient's different, every athlete's different, and it's going to impact some athletes differently, the same way it'll impact patients differently. And it's really looking at that athlete from their own perspective and looking at them uniquely and doing what's best for them instead of just doing the same thing for everyone. So yeah, interesting rant by Joey Barton, and it's just another case of bringing the eyes on sports dentistry and how important it is to have that sports dentistry support for athletes.
Yeah, I think what he's maybe alluding to is possibly more along the lines of when you're reorganizing inclusion. I think doing simple cosmetic bonding or doing simple restorative work or simple aligner work isn't much of a big deal, but maybe these athletes have been getting their occlusion reorganized, which is then potentially disrupting the way that it is disrupting, isn't it? The way that the mandible and maxilla come together. So that there must be something. And then, like you said, that's your area of expertise the last 15 years or so. But I don't think the very simple restorative dentistry I can't see how that would make much of a difference, but I do understand if it was a bigger project. So then do we have to then tell the athletes, look, if we want to do a bigger treatment here, if we need to start reorganizing things, there is a risk that you could get injured? Where does that leave us though? Because there isn't a cause and effect here, or a relationship with it. There's no studies potentially that we could do to say that you've had your teeth done, now you've got this injury. I'm not sure how that's going to develop as time goes on. So it could just be a case of with somebody like Joey saying that it's something for us to look into a bit more.
Yeah, definitely. I think it is something that needs reviewed, rather than rule it out or to say, actually, no, there's something going on here that we need to have a look at. And yeah, especially with the way how popular cosmetic dentistry is getting, more and more athletes are getting it done compared to maybe a decade or two ago. And it's almost becoming the norm that athletes are getting their teeth straightened or they're getting their teeth whitened or they're getting veneers or they're getting a full mouth smile rehab to improve how they feel and how they look. It's definitely becoming more common, and it's an area that we maybe have to put a little bit more focus on to say, is there a cause and effect? Is there something there that can negatively impact or even just monitor it initially? But definitely it's an area that needs a little bit more focus, a little bit more research, and definitely an area where we as sports dentists can help.
Yeah, because I think if you're going to say to an athlete, there is a risk that this could have a negative impact on your performance or your potential to get injury, that changes the game. Like, that's a massive game changer for dentistry in general. But until there's evidence to suggest that, I don't see why we would need to alter our approach. But certainly it's something that we need to look at and identify and open our eyes a bit more to that potentially being an issue as time goes on. The more the athletes are getting it done, like you've just said, the more and more athletes are wanting to get it done. So it's something, if there's someone listening out there who has a interest in that sort of field, or they have money behind them from a big university that's willing to fund the research, then it's maybe something to look at.
Yeah, it definitely would be interesting. And some of them sort of develops as well. You could have a scenario where you have a sports dentist associated with a team, particularly in soccer, because we're seeing it a lot in soccer, because possibly with the disposable income a lot of the soccer players might have, it's a lot bit easier maybe for them to get a smile reconstruction done. But it could be where you have your sports dentist associated with the team, but the players are actually going to a different dentist to get their cosmetic dentistry done. But it's maybe trying to link that in where the sports dentist knows what's happening, so they can put that as part of the athlete's profile, so they can, and maybe then it's easier then to monitor if there's maybe more issues afterwards. But there could be other factors involved as well. Could be a trauma they received, during a match that's led to it as well at the same time. But it's really just having that full picture of what's going on with that player or that athlete, so they can help that medical team try to ensure that athlete is prepared, or the athlete best prepared to prevent injury or recover from injury. So it's maybe that scenario as well where it's we know that it's happening and it can be monitored, rather than saying you shouldn't be doing it just in case.
Yeah, definitely. I think that's a conversation that needs to be had, and what better time to have it than at the second Sports Dentistry Conference in Manchester on the 12th of September. And ticket sales have been live for a couple of weeks now, and there's been really great interest. There's been a lot of messages asking about it, and ticket sales have been going well. But, the more the merrier.
Yeah, looking forward to it as we're getting closer. And as we're building it up on the socials and conversations with other sports dentists, it's going to be a good day. And it's September, so I'm expecting the sun to be out. Tenerife weather, maybe. We never know. We might get a good September, but it'll be a great day. Meeting up with colleagues, getting some education, networking, socialising over the dinner, and then heading to watch international cricket. Like, no matter what sport it is, when you're watching the elite players play, it's absolutely unbelievable. Just the speed of some of the games and the athleticism of the players, no matter what sport it is, it's always a great spectacle.
I mean, if you've never watched live sport, when you go for the first time, you'll never forget that experience, the first experience you ever have, especially at that level. You're watching the best players in the world performing their craft, what they're getting paid for, what they're getting paid to do. And September, the weather tends to be quite good in September. Manchester is quite known for being wet and windy. However, if the sports dentistry gods out there will shine the light on one day, please let it be. Please let it be that Friday.
Yeah, I'm sure it is. Talking about the UK Sports Dentistry Association, our next guest is the leader of one of our partners, which is Dental Trauma UK. And we seen her present at the first conference, and as you mentioned before, the passion was fantastic, and just what they've been able to develop in the Dental Trauma UK. I didn't realise just how much work that they went into it and how much support that they have for the members. I was a little bit blown away by that, and it gives us something to aspire to from the UK Sports Dentistry Association to match what they've been able to achieve.
Oh, absolutely. And I think the resources they have available on the Dental Trauma UK website is mind-blowing. I think we were all blown away last year when she was talking about what they actually have available on their website, step by step, of pretty much every single dental trauma you can think of, step-by-step videos, step-by-step instructions, videos and posters that you can use in your practices and out with. Certainly the Save a Tooth video, which if you've not seen it, it is a brilliant animated video of how to save a tooth for the public. And also they did the campaign in Glasgow at the train station, which again, she talked about that, and it was called the
Selfie Your Smile. I thought that was absolutely fantastic.
Selfie Your
campaign.
Smile. Yeah.
Selfie Your Smile. Not only the name, which is very catchy, but the whole principle was that you would take a selfie of your smile. So if you were unfortunate to have some dental trauma and there was like a dislocation or a luxation of the tooth, then you'd be able to show the dentist your selfie smile before the incident, and I would hopefully help aid them to get things repositioned back to where they were before the trauma. I thought just that was an absolute great campaign, and just for it to come up with it and have a great slogan with it as well. Really catchy slogan, and hopefully it's something that does really take off, because you can see how it can be very useful for the dentist that's supporting someone that's had dental trauma.
Oh, absolutely. And just as we were talking to before, I've actually got a young 12-year-old girl booked in on Friday who's had dental trauma, being hit in the face by a hockey stick, and she's been to see the Dental Institute here, and they've referred it to me to restore these teeth. And I actually asked the patient's mum to send me a photo of what the teeth looked like before, so I'm able to then visualize and see how I'm going to try and restore these on Friday. So that the timing of that again is unbelievable. I think it's just again opened my eyes again to, although I was kind of thinking about it this morning, the fact we were just doing a little bit of research there and reminded ourselves that they did that Selfie Your Smile campaign. And I think it's super important that people try and advocate that in their practices. I'm sure we'll be able to get some content together and be able to maybe distribute to the listeners. So if there is something that they want to get to put into their practices, then I'm sure we'll be able to get maybe some presentations or some posters together to send out to them.
Yeah, so I'm really looking forward to this conversation. She can explain how they started Dental Trauma UK and how they were able to develop. It's going to be really inspiring. So let's rock and roll. So our guest today is going to be Serpil from Dental Trauma UK, and it's going to be fantastic.
Yeah, I'm looking forward to this one.
Hey everyone, save the date. The UK Sports Dentistry Association's second conference is happening on Friday the 12th of September at the Voco Hotel in Manchester. And guess what? It's not just about teeth. We're combining cutting-edge sports dentistry talks with the thrill of live sport. Right after the conference, we're heading to Emirates Old Trafford for the England vs South Africa T20 International. Expect a day packed with expert speakers, athlete Q&A sessions, and plenty of time for networking with dentists, sports pros, and athletes alike. Whether you're in dentistry or passionate about sport, this is a day you won't want to miss. Tickets are live now at sportsdentistryuk.com. Grab yours and join us for an unforgettable day. I'm delighted to welcome as guest on this podcast, Serpil Djemal. Did I get that right, Serpil?
You did.
Just about. Serpil has been one of the leaders from Dental Trauma UK, so we're really looking forward to this conversation. We have been bigging you up a wee bit, Serpil, no pressure. We've been bigging you up over the last few weeks in the podcast, but I think both myself and Umar were really impressed with your presentation in Edinburgh and your enthusiasm. So we're really looking forward to this conversation.
Thank you, John. Thank you, Umar.
So just a wee bit for the listeners and probably for ourselves as well. Just can you give us a little bit of a background on how you got into dentistry, that sort of path, and then what led to the formation of Dental Trauma UK?
Yeah, sure. I'm delighted to be doing one of your podcasts. So thank you very much for inviting me. I'm a baker's daughter and I grew up in North London, and I've got 4 siblings and all of them went into the family trade, into the bakery trade, except me. I decided that I wanted to go to university. And I remember as a child, we always used to watch movies and my sisters would say, "Oh, hasn't he got lovely eyes?" And I would always say, "Oh, he's got nice teeth." So I was fascinated or attracted to teeth from a very, very young age. I went to university and I went to King's College Hospital, and I felt a bit of an imposter being a baker's daughter. So I spent my time at King's trying to learn as much as I could and do as well as I could. And I really, really enjoyed it. I've got practical skills and I loved doing dentistry. It was a passion really. So it wasn't hard work for me. When I qualified, my first job was with Martin Kelleher at King's as a house officer. And at the end of my time with him, it's quite funny. At the end of my time with him, he always sits down we were called senior house officers then. He sat me down and he said, "Okay, where do you see," I can't do his accent, sorry. "Where do you see yourself in 10 years time or 5 years time?" And I looked at him and I said, "With my name on your door." So his office door, by the way, no other door. So that was really, he was taken aback. And since then, he's been my number one fan, my mentor. And if it wasn't for Martin Kelleher, I would say that I wouldn't be where I was in dentistry at all. So that was the start of my career, really. I then went to Canterbury for a year and did orthodontics and maxillofacial surgery. And that was great. And I was inspired by John Storrs, who was the max back surgeon down there, and Geoffrey Webb. And he was the orthodontist. And I remember thinking, I'm going to be like Mr. Keller, so I'm going to do a cons MSc. But after my time with Jeff Webb, I just thought, oh, if I don't get into cons, I'll do orthodontics, because I was inspired by him as well. Fortunately, I got into the cons MSc at the Eastman. And after that, did the usual 3 years, 4 years as a registrar. And then I did 4.5 years as a senior registrar. And I'm giving out my age here because they don't exist anymore. They're now called specialty trainees. At the end of my higher specialist training, I became a consultant at the Royal London Hospital, where I met another one of my inspirations, which was Paul Wright. He was the dean there, and I was the first consultant in restorative dentistry that they had recruited for the Royal London. And I'm pleased to say that although my focus at that time was hyperdontia and oncology, after 9 years at the Royal London, I left them with 5 consultants and a whole load of junior staff. So, I got the knack of sort of developing, finding money from wherever you find the money, and then developing departments. And I really enjoyed that. And then after 9 years, I went back to my alma mater, King's College Hospital, and became a consultant at King's. So that's and then I retired a couple of years ago after 14 years at my alma mater at the end of my career.
Very good. That must have been quite a proud moment whenever you went back to King's and then you did a full circle on what you set your sights on.
It was lovely. I mean, it was difficult because I left there as a trainee, and then to go back and to, be accepted as a consultant by not junior staff, but by the staff that I knew when I was a trainee was a little bit of a challenge, but it didn't take long to sort of fit straight back in and then do great. I thought I did great things, and I had a wonderful time in the last 14 years of my career. Really, where my passion for dental trauma began, because they had, as you know, every dental hospital will have a pediatric department that sees children that have sustained a traumatic dental injury. What was lacking was really somewhere for adults to go where they could get definitive care, restorative care, not max fax type care where their aim is to, put them back together and save their lives. We wanted to save teeth. And I didn't develop the adult dental trauma service at King's. It was already developed. It was run by a max fax surgeon and processed or serviced by acute dental care with oral surgeons. So the emphasis was slightly different to restorative, which was where I was coming from. So when I saw this service, I thought, I'd love to run that service. But obviously, as you know, if you put your hand up to say, can I do that, please? Everyone is, no, it must be good. If Serpil wants it, it must be good. So I sat and waited, and it was 2 years before they turned around and said, Serpil, would you be willing to take on the trauma service? So I thought, yay! But I had to be controlled and said, let me think about it. But long story short, I did think about it. And the next day I said, yes, I'd love to take it on. And that was when I sort of developed. I didn't start the first adult dental trauma service in the UK. I developed the first one. So it had a total facelift when I took it over and brought it into restorative dentistry.
So what sort of things did you introduce then? You said you took it over and kind of started it from scratch. Talk us through that transition period, what sort of things that needed to change and to look forward to.
Yeah, good question. First of all, I had to develop my knowledge and skills in management of dental trauma, because I remember the first case, or one of the first cases that I saw, was really quite 6 upper teeth, 4 lower teeth, all displaced and all over the place. And I remember looking at it and trying to reassure the patient with a smile, say, don't worry, we're going to look after you, and reassured them. And then I remember saying, I won't be a minute, walked out, and I walked into the corridor and I went, oh my God, what am I going to do? So I knew that I had to very, very quickly develop my knowledge and skills on the management of dental trauma as well, which I did. And I'll share with you shortly where I went for that information. We developed a trolley. We had a trauma trolley. So all of the essential, and there's not a lot of equipment that you need, but there's essential equipment that's required. So I purchased 2 trauma trolleys, and we basically developed 2 of them side by side, and they contained anything and everything that you need to manage dental trauma. And that include topical anaesthetic, which wasn't being used before, and the local anaesthetic, plus the splinting wire, the composite, anything that you need. And it wasn't anything and everything. I'm quite an efficient worker. So I'd slimmed it down to what are the essentials that we need to move the trolley. So you didn't have to have one chair waiting for a trauma patient to turn up. You could roll the trolley wherever you were working and manage the patient. That's why it had to have everything that you needed. So the type of treatments that we changed almost immediately was if there was a tooth that had a complicated crown fracture, so the pulp was exposed. I know that in the acute dental care service, they would extirpate the pulps, dress the tooth, and then discharge the patient to the dentist to do root canal treatment and restore the tooth. What we did immediately, day one, was spec pulpotomies or partial pulpotomies on these teeth. In adults, remember, because the majority of my patients were adults. And a lot of the early research by spec was done on growing patients, so children and adolescents. And so we kind of led the way to doing the partial pulpotomies in adult patients. And it's amazing how quickly, you saw that it worked, and it's quicker and easier to do at an emergency appointment than to anaesthetize, place rubber dam, extirpate the pulp. So it was also more time efficient to do this treatment as well. But obviously, if it was appropriate, if you had a necrotic pulp there, you couldn't do a partial pulpotomy. So it was doing the correct diagnosis and then changing the way we manage teeth. Also, I know, and I met lots of patients that had extruded teeth, some that were wafting in the wind, and they would go via Max Fax if it was out of hours. And what would Max Fax do? They would just take them out and suture them up and stop any bleeding with hemostasis. And what we obviously started to do very, very early on was reposition these teeth, put them back in position, and then obviously splint them according to the IADT guidelines.
I mean, you've just talked about their check pulpotomies. I just want to ask you right away. So someone who's listening right now, a golden nugget information, what should a clinician do? Adult trauma, enamel dentine fracture, pulps exposed. Just talk us through that initial presentation to what they should do in that appointment that they've got. Say they've got a 10-minute emergency appointment. Talk us through what your steps would be then. Okay,
so I would put topical anaesthetic in the sulcus and ask the patient some questions, or take some photographs, or, use that time to actually, because I've only got 10 minutes. So put the topical anaesthetic, anaesthetize, And most often, these complicated crown fractures were in the upper labial segment. So it's easy to isolate using cotton wool rolls in the sulcus and then a piece of gauze on the tongue and behind on the platal aspects of the upper anterior teeth. And with a nurse, good isolation. That gives you good isolation. The only time I used rubber dam was when the patient who turned up was the daughter of a retired dentist and he turned up with her. So at that point, I used rubber dam and I took photographs because I wanted to show that you can use rubber dam as well. But in the upper labial segment, you do not need to use rubber dam. You're not using anything that you're going to drop down the back of the throat. It's basically to stop saliva from getting onto the pulp. Once you've anaesthetized, and with spec pulpotomies, you don't need to do palatal infiltration at all. It's just the labial infiltration. Then using a small round diamond burr with water coolant, you remove the top 2 to 3 millimeters of the pulp. You then get a small pledget of cotton wool, dip it in sodium hypochlorite, blot off the excess, and then apply pressure to the pulpotomy that you've just prepared. And I learned over the years that you then count to 3. 1, 2, 3, and remove that pledget, and then observe for 3 as well. 1, 2, 3. If you get a little spot bleed and a trickle of blood, you pick up your small round diamond burr and you remove another 1 to 2 millimeters of the pulp and repeat the process. And you keep doing this until you get lovely, healthy looking pulp. And you're going to say to me, what does lovely, healthy looking pulp look like? It looks like a very pale raspberry jam that isn't bleeding. So you observe the pulp and it does not bleed. Once you're at that stage, if you do that stage in an adult and you get down, all the way down to the cemento-enamel junction, so the cervical level, then a pulpotomy is no longer appropriate. You need to put your burr down, get your rubber dam or temporize and get the patient back to put rubber dam on and do root canal treatment. In a child with an open apex or a growing out child with an open apex, even if you get down to the CEJ, you must do a pulpotomy because what you want is to maintain the vitality of the pulp, and that encourages and develops the roots so you get continued root formation. And that way you get a nice, strong, robust root and not thin, spindly dentinal walls of your root. Once you've got lovely, healthy pulp, you then put your bioinductive material on and you can use MTA. But we didn't. We tried it and then went back to using calcium hydroxide powder mixed with saline because 1, it's cheaper. 2, it doesn't cause discoloration, which the white MTA can do. So we went back to using calcium hydroxide. And if you haven't got calcium hydroxide powder, then just using non-setting calcium hydroxide paste will be fine as well. Seal that over and then build up your tooth with composite. And when I say seal it over, seal it with glass ionomer and then build up the tooth with some composite resin. If you are planning to reattach the fragment, if the patient has the fragment in their hand and you're planning to reattach the fragment, then you need to make sure that your pulpotomy preparation, the cavity in the pulp chamber, needs to be deep enough to accommodate your calcium hydroxide and your glass ionomer without being proud of the root surface. Because if it's proud, then when you put your fragment back on, it won't seat properly. And if you haven't got it seated beautifully back in the right position, the cement lute is compromised and the fragment reattachment won't last very long.
I saw a trick someone used where before you did any of that, they would place the fractured segment onto it and take a putty index of that. So then they know it's going to seat perfectly over the top. So I suppose that's another way of doing it, to know that if you're guesstimating trying to put the fracture segment on, but I suppose that adds time into it, extra 1 or 2 minutes.
Yeah, it adds time, Umer, but also people were doing that because they were, from what my knowledge, they were actually beveling the fragment and beveling the tooth because they were trying to get rid of that join line. But I think it makes it too fiddly, it makes it longer, and it doesn't always get it back in exactly the right position. So my advice is don't bother with that because it's quite easy because you've got 2 pairs of hands, you've got good isolation. It's quite easy to relocate the fragment, run a probe before you cure, run a probe from the tooth to the fragment on the platal and on the labial side, make sure there's no steps, and then ask the nurse to do a quick we used to use very quick curing lights, but just if you're using a 15-second curing light, then just do a 2-second cure, clean off all the excess, and then fully cure. If the join line is a problem at a later date, at a subsequent appointment, then what can you do? You can drill out a little channel in the join line and create your bevel at that stage and then blur that line in. But I have to say, in my career, and I was doing dental trauma, I would say about 14 years, nearly 14 years, I only had to do that on 2 occasions.
Wow, that's that over 40 years. That's extremely
14,
successful.
14.
14. Yeah, I said 14.
Yeah.
Yeah.
I thought you were trying to age me.
No, not at all, not at all. Just before we move on to the next bit, you explained that so well, and I was just writing everything down there. I was like, yeah, that's makes so much sense. Biodentine. What's your thoughts on that?
So I used biodentine when it was first introduced into the market. And for me, it was technique sensitive. And, I struggled with it. I remember the first day I tried to use it, I scooped it out, I cleaned the area, and I went back to using calcium hydroxide.
The setting time for biodentine is 12 minutes. That's why then it extends everything.
The mixing was really problematic at the beginning, and you had to get the right number of drops to the powder, and it was really technique sensitive, and the setting time was really, really long. I know that the formulation is much better now, and if you have it in your surgery, then by all means use that. That's great, because we know that MTA and biodentine give a better dentine bridge formation. You get a much more ordered dentine being laid down compared to calcium hydroxide, where it's a little bit random and a little bit sort of porous and hickledy-pickledy. And you get less inflammation if you use MTA and biodentine than calcium hydroxide. But the long-term survival of the pulp, which is what we're aiming for, doesn't appear to be affected. So it seems to work just as well to use the calcium hydroxide that gives a little bit more inflammation of the pulp and the slightly more porous dentine bridge. So don't go out if you're, looking to improve your trauma management. I wouldn't go out and buy MTA and biodentine. Start off simple, because remember, trauma patients turn up randomly. As a general dental practitioner, you'll probably see 3 or 4 acute dental traumas a year. Because we set up the adult dental trauma service at the beginning, I was seeing 1 or 2 a week. Very quickly, as everybody started to learn that we were doing acute dental trauma for adults, then it became, 1 or 2 a day. Towards the peak, at the end of the data collection, because we collected data on all the patients that we saw at King's as well. Towards the end of the data collection, we were seeing 3 or 4 patients a day. Now, they weren't all appropriate for trauma management. Some of them, when you assess the whole mouth, you thought, well, they're already wearing a denture, they've got a bit of gum disease and some caries. That isn't the best thing for that patient would be to have that tooth added to their denture. So you have to do a full assessment of the case and decide, 1, what the diagnosis is, 2, what's the appropriate treatment in this environment for this patient, given their medical history, their smoking status, or whatever else that you're considering.
I think that's a very good point, that you don't necessarily need to go out and buy all these advertised materials and stuff. A lot of that process that you described there and the materials you described are all readily available with the root canal treatment kit that would be in the clinic anyway for doing root canal treatment. So
Correct.
It's not necessarily something that somebody that's looking to get a little bit more comfortable with doing dental trauma and stuff. They don't necessarily need to go out and start getting lots of different equipment or lots of different materials. It's just knowing how to use what's already available in the clinic.
Absolutely right, John. It's about knowing what the principles, what you're trying to achieve, and what have we already got that we can use. So as you say, for root canal, you use hypochlorite already. So that's going to be great when you're applying pressure for the pulpotomies. Odontopaste, non-setting paste that could be used on the pulp as the bioinductive material. Yeah, so using what you already have, because also remember, you might spend a lot of money on something and everything has a shelf life as well. So by the time you get around to using it, it might go out of date, and then it's a real faff, about wasted my money. I'm not going to do dental trauma anymore.
Yeah. How did you develop then? So if we move on to Dental Trauma UK, how did that come about and how did that develop?
So remember I said that one of my first cases, lots of teeth displaced, and I walked into the corridor and I went, oh my God. I didn't say, oh my God, it was more F words that I was saying. And I thought, I've done all this training and I don't know a lot about the management of dental trauma, let alone adult dental trauma, because we got taught a little bit at undergraduate and as I did some of my training on pediatric trauma, but adult dental trauma, not maxillofacial trauma. I'm not talking about that. I'm talking about adult dental trauma. So trauma to the teeth alone and the soft tissues, obviously, but no fractured bones or anything. I thought, I don't know enough. So I then started to read and I should have got the book out to show you guys. I know the listeners can't see the book, but the Andresen big gold, I think it's worth £1,000. It's not that much, but it's a very expensive book. So I read that cover to cover. I joined the Dental Trauma Guide. At that time, it was free. So I studied it. I downloaded it. I had it available in the trolley that we had, the trauma trolley, and basically just started to teach myself. But the best way to learn, I found, was to do it, to get on. And I was very lucky. My patients were unlucky that they'd sustained the trauma, but I was very lucky that I then had the chance to put what I was reading into practice immediately. So I then developed the skills on managing dental trauma. But I wanted to share that because I developed a lot of knowledge and skills. And I thought, but, it's all very well and good me doing it, but I can only see a certain number of patients. So we developed it within the department and we got MKIN students from King's College London to come over and they were doing part of their endodontic training. And part of that was servicing the trauma service as well. And so they got experience in managing acute dental trauma. And I just thought, we need to improve education in dental trauma. So I was seeing a friend for lunch one day, not a dentist. And I said, Roland, he's also a member of the board of Dental Trauma UK and has been a founder member of the board right from the start. And I said, Roland, I really, really need to set up a charity about educating people, not people, but the dental team on how to manage a trauma. But also, I was a bit fed up with people walking in with their avulsed tooth wrapped neatly in a tissue, bone dry. And I thought, well, the message is already out there, but they don't know it. So we wanted to educate the public on what to do if you avulse a tooth as well. So I said, Roland, I really need to set up a charity. How do I do this? I really I'm a dentist. I'm not, I don't know how to go about doing this. And he looked at me and he went, I can help you, because he'd set up a charity before. And long story short, after, I think it took us a year, but we had pro bono services from a solicitor friend of his who helped us with the application. It took us about a year until we got charitable status. And then it's grown since then. So we have developed a website where we have some patient information on what they should do if they knock a tooth out. We also have information about mouthguards, but we're about to update that, especially after my attendance at your conference. I thought, wow, there's so many, brilliant people here that can help. And Rhea has agreed that she will try and help us update our information on mouthguards for the website. So that's really how it started.
Yeah, I've got to say I was absolutely blown away at your presentation last year. I didn't realise the full extent of the Dental Trauma UK website and just how much information and education was on there, and just your sheer enthusiasm for dental trauma and with the experience that you've just described there. I said to John, I was like, John, we need to get Serpil on early onto this podcast because I just think it's going to attract so many different people from all over the world to hear about your experiences, especially if you were doing that much adult trauma on a daily basis by the end of your career. And the Save a Knocked Out Tooth video I thought was fantastic as well. I love the music to it. The music's fantastic as well. So we'll definitely provide a link for the listeners to this podcast so they can go onto the website and have a look at the video too. But just the step-by-step videos that you have on the website as well, I think it's just so educational. So I want to say thank you, because I think you will definitely provide more confidence to the general practitioner, not just the general practitioner, but for us as sports dentists. So onto the pitch side, which we'll come on to in a minute, but in terms of pitch side management. So, but definitely, I think people are going to really gain a lot of knowledge from that website.
Thank you, Mayor. Yeah. Did you notice the voiceover? Did you recognise the voiceover on that animation?
You're
It
going to
was
have to answer that for me.
a boy and a girl or woman. Well, the woman was me. That's my voice on the animation.
Oh, I was just so engrossed in the video, I didn't even pick up the voices.
Yeah, no. And I was lucky at the time when we were developing the idea for Dental Trauma UK, there was an opportunity to apply for some funding. So I managed to get, I think it was a couple of £1,000. And I managed to, with that, source somebody that I saw had done a video, similar animation for another charity. And I approached her and she came and gave us a really good deal to do the animation for us. And it was really, I was really pleased with the end result as well. Before I move on, though, I've said a couple of times that King's was the first adult dental trauma service in the UK. I am really chuffed because following our footsteps, there are now several adult dental trauma services in the UK and Scotland as well, I should say. Beth Burns is the adult dental trauma service lead in Glasgow. We've got James Darcy in Manchester. I think it's Claire Forbes-Haley in Bristol. Fadi Jarad in Leeds. So all of these restorative people that have seen what we were doing at King's, and a lot, I mean, not all of them came to visit, but they definitely made contact to pick my brains on, how to develop a service. And now they're doing great things in their local patch, which is what it's all about. And I know that Lyndon Meehan is looking to develop an adult dental trauma service in Neath, Port Talbot. So, anyone out there, if you have any ideas and want to develop something locally, more than happy to help.
Yeah, that's fantastic. And just if we go into the Dental Trauma UK as a member, I know there's a lot of great information online for the general public as well. But as a member, we've been very fortunate to work with Sports Dentistry UK, with the UK Sports Dentistry Association, and that any member or anybody that joined was a member with us last year also had the luxury of being a member of Dental Trauma UK. Can you describe for anybody out there that's maybe not already a member of Dental Trauma UK the benefits of being a member and what Dental Trauma UK offers?
I'd be delighted to. So just to say though at the beginning, so we've been established for 10 years. We had our 10-year anniversary last November. The membership fee 10 years ago was £30 a year. Yeah. We've developed all of the resources and we've got over 50 hours. And I'll tell you what else you get as a member. But we've developed things and there's a lot more on offer now with the membership with DTUK. But guess what the membership fee is now? £30 a year. So we haven't, because the whole point of being a charity and the whole point of sharing what we know is to encourage people. We don't want people to think, oh, should I be a member of Endo Society or Dental Sports Association, or I want them to be a member of as many, but definitely for dental trauma, because dental trauma overlaps a lot of the other societies as well in what they do. So we've kept the price at £30 a year, and I want to. That's our only income. We have no sponsorship. We have no grant money. We have no fundraising. It's purely from our membership subscriptions. And we do offer a corporate membership to large groups. The smallest group we have is 25 corporate membership. And I'm delighted that Sports Dentistry UK Association or UK Sports Dentistry Association. Yeah.
It's okay. I've mixed it up because it's UK Sports Dentistry Association, but I've made the website and the handles all Sports Dentistry UK. So I'm mixing it up myself.
That's right. I like Sports Dentistry UK. I like that one as well. I don't think you need the association bit on it, to be honest, but it's got to be easy to trickle off the tongue, you know. So you guys are now corporate members with us at DTUK, and what we offer is free attendance. I better not forget anything on the list. Free attendance at what I called the Bish Bash Bosh, and this year it's 2025. And basically, Bish Bash Bosh is the annual, used to be the conference that we ran, but since COVID, going on webinars and surveying the members, and they actually prefer to stick with webinars. I like face-to-face, I like seeing people, but it seems to be easier for people to attend webinars. So you get free attendance to up to 6 webinars a year. That gives you each one will give you 1.5 verifiable CPD points. You get access to the dental trauma guide. So to become an individual member or subscribe to the dental trauma guide is $60 a year for me as Serpil Djemal to subscribe. But we buy corporate membership from the dental trauma guide. So that means that any one of our members, whether they're full paying members or corporate members with Sports Dentistry UK, then you have access to that dental trauma guide. I have developed, it was Fiona that helped me, Fiona Clark, developed 2 papers that we wrote on fractures and one on luxations, and she converted them for me into 2 modules. And basically it's a bit like the dental trauma guide, but it's real life cases that I use in my teaching material to actually go through, and you can click on the different injuries. You can click on spec pulpotomy and it will show you step by step what to do, including videos. So it's slightly more elaborate than the dental trauma guide. It's not as academic as the dental trauma guide because they have all their stats at the end that you can, develop graphs, etc. But what we have on with our modules is a quick reference access if you want to go through, better than reading a book because you're seeing videos and things and listening to my voice a little bit here and there as well, giving little tips and tricks. But also, if you do it, go through the whole module, and there are 2 of them, once a year, you have the opportunity to do a multiple choice question. And if you pass that, and I'm sure you will, if you pass it, you get 2 hours of verifiable CPD once a year. So it's a bit like your basic life support training that you do every year to make sure that you maintain your skills. Well, this is an opportunity to do that with dental trauma, pay no extra money for it, and get your verifiable CPD as well. You can't do it more than once a year, but once a year you can go ahead and do that. We've also got patient information leaflets. We've got anybody that's a member that wants a copy of the animation. I'm happy to give them a copy of the animation on the beginning of the website because we want to spread the word. I'm not precious about, it's mine, I'm keeping it, it's mine, I created it. It's about who can see it. Let's get everyone out there to see it. We want to share it so that patients get the best deal when they go for their management.
Yeah, it's absolutely fantastic. I didn't realize how much resources there was until we started working together and I started looking into it. So what you've developed at Dental Trauma UK as a resource for dental professionals looking to get more confidence and having that reassurance when it comes to dental trauma is fantastic. I want to touch on a campaign that I thought was amazing when you presented it in Edinburgh, and that's the Selfie Your Smile. I thought it was it was so smart and such an intelligent way to get something that could be so useful. So can you give us a little bit of a background on it and what the campaign was and things like that?
Yeah, I'm glad you've asked me that as well, because this is really imminent. It's about to be launched not any day. We know the date's going to be launched. So when I first started doing dental trauma, if you have one patient come in with one displaced tooth, it's quite easy. You see where the socket is. It's quite easy to know where to put that tooth back. But if you have upper and lower labial segments affected and the teeth have either been avulsed, displaced, locked in position, then sometimes it's quite difficult to know exactly where to put the teeth back. And I had one particular girl come in, and this was quite early on in my career. And I'll give you a bit of background on what happened to her. She was carrying her friend. She was 18 at the time. She was carrying her friend on her back. She was giving her a piggyback in their front room. And they were just messing about, as girls of 18 do. She tripped on the rug and then with her friend on her back went full face down onto an oak coffee table and took a bite out of the oak coffee table. She didn't actually take a bite out of it, but she gave me a picture with her teeth marks in the solid oak coffee table. She went to a Max Fax unit near where she lived and they put her back together in inverted commas, splinted, and then told her to go and see her dentist. 2 days later, the splint came off. The teeth started to wobble and she thought they were going to come out of her mouth again. So she went to another Max Fax unit who put her back together in inverted commas again and splinted and sent her to her dentist. As soon as her dentist saw her, they picked the phone up to me and said, "Serpil, would you see this patient?" And I said, "Yes, send her in." And she was one of the ones that I went into the corridor and I went, oh my God, what am I going to do? But I sat, obviously went through the history, you know, tried to understand. She wanted all her teeth out. She was 18 years old. She wanted all of her teeth out because she was in so much pain. And I convinced her that no, we know what we're doing and that we will try and save her teeth and my splint will not come off. I guaranteed her that my splint would not come off. So I'm looking, thinking, did you have a gap between your front teeth? And I asked her, did you have a gap? And she said, no. I said, are you sure? I went back to the radiographs, looked in the mouth. I said, are you sure you didn't have a gap over here? I wasn't sure where her teeth should have been. So I said to her, do you have a photo of your smile before the accident? She looked in her phone and she said, oh, no, I haven't, but I've got this. She'd been to the hygienist 2 weeks before her injury. And when she came out of the hygienist clinic, she took a selfie of her mouth to see how clean her teeth were. She wanted to zoom in and see how clean her teeth were. So I was then able to use that selfie to put her back together again. And I think we got a really good result. She had quite a bit of recession and around some teeth, but that was because of the bone loss, the alveolar bone plate being lost or resorbed as a result of the trauma. So that made me think, and so we started asking every patient. And then I thought, no, we need everyone, young, old, it doesn't matter their age. My oldest patient was a 90-year-old lady who laterally luxated her upper central incisors. She died at 99 years of age and she still had her 2 teeth in her mouth. Yeah. So it doesn't matter who you are, what age you are, everyone should have a selfie of their smile. So we are launching this campaign to encourage anyone, young and old, to take a selfie of their smile, just in case they're unfortunate enough to actually fall over and create some serious damage to their teeth. Then it would help their dentist or the healthcare professional that's helping them to put their teeth back together and restore their smile. So that's what we're doing. I'm delighted to say that the British Society for Paediatric Dentistry I showed them what we were planning to do. They loved it, that they are on board. So we are doing it as a joint campaign together with the BSPD. So that to me is my dream, for dental trauma and BSPD to come together and to launch a campaign like this. So we're planning to launch the campaign in June after the Oral Health Foundation have finished their month of, I think it's Feed Your Smile this year. So as soon as that's over, I think we're planning for the 24th of June, we're going to launch Serpil Your Smile. So we'll be in touch with everyone at Dental Sports UK. No, sports. So yeah, anyway, you decide.
UK sports dentistry.
You can say whatever you like, Serpil. We'll all listen, don't worry. It's actually funny you should say that about the Selfie Smile campaign, because actually just a couple of weeks ago, just before I went on a holiday, I had a girl come in, 12-year-old girl who'd accidentally been hit in the face by a hockey stick by her mum. They were playing in the garden, long story short. And she went to the dental hospital then referred to me to Restore the Central. And I was saying to the practice manager, and I was saying, do we have a photo? Give me all the records. And then, so the dental hospital sent me the x-rays, they sent me the trauma photos. And I was like, actually, we need the photo beforehand so I know exactly what I'm dealing with. And it wasn't until I had a quick conversation with John, we were talking about something separate, and he was like, oh, do you remember that campaign? I was like, yes, I do remember that. And then I got the mum to then send the photo, and she came in. I'm actually going to review her next week, so I'd like to see the changes, but just even little mamelons and just, the translucencies, all that sort of stuff. And it made a massive difference, because then you're clearing your head where that position of the tooth was, and there was a big diastema there already, and then she still had the upper lateral there, so there's impact of the canine. So I was like, trying to, rather than overthinking it, being very clear in your mind before the patient comes in to sit in the chair. And I had that few extra days to be like, okay, this is what I'm going to do. And it made a massive difference. And everybody's got access to a smartphone, and everybody's got access to the selfie. They know how to do it. Kids know how to do it. My 6-year-old know how to take selfies. So there's no real excuse, but if you do have those photos available, it makes a massive difference.
Yeah. I mean, I have to say, I was at the World Endodontic Conference last year, and I was speaking to, I think it was the treasurer of the IADT, the International Association of Dental Traumatology. And I was telling him about this campaign, and he was going, wow, that's very nice. Very smart. Yes. He's saying, yeah, I wish we'd thought of that.
You get a copyrighted. I thought the exact same. I thought it was a brilliant initiative, and it's so useful. And anybody that's listening here, if you're involved in any associations, any other sports day associations, get behind it and promote it. I know on the 24th of June, I'll be over in Washington at the Academy of Sports Dentistry, and I'll be promoting it over there. Hopefully, they can add it onto their socials and get it around their members, because it's such a useful thing to have for a dentist if they're involved with that trauma, to have that as a support, to know where to try to get back to.
With our membership, I just want to say, with our membership, we have 22 what we call regional representatives. And these are people all over the country that are really keen on dental trauma and will go into sports associations and to mum and toddler clubs, so everywhere and anywhere that they have access, to try and spread the word on prevention, but also management, what happens if. So what my campaign manager and I are putting together is a toolkit on stuff that they can then go and take to sports clubs, etc. So what I think we'll do, rather than send it to our regional representatives alone, I think we'll just share that with every single member of DT UK, and that will include the UK Sports Dentistry Association members, because you're all corporate members. And if you're not already signed up, sign up. It's free. And I know they say there's no such thing as a free lunch, but John and Umair are going to be paying for this membership for you in the future. So it's not free. It's not free. It's free at the moment.
Yeah, get on early while you can. No, it's great. Yeah, we'll be hoping to keep that close tie with the UK Sports Dentistry Association, because it makes such sense for having that support. Then, for dentists out there that are maybe just getting into trauma, and it's maybe a little bit overwhelming to them, what would be the most common dental trauma that you would have seen over the years? So, like, what are they most likely to see first, so they can maybe get themselves feeling comfortable doing that type of treatment? What are the sort of things that you get them to focus on if they were first getting into dental trauma?
Okay, so the most common, and this is the same with the European data and with the King's data, the most common type of fracture injury is the uncomplicated crown fracture. So make sure that you're really good and quick and slick at doing composite build-ups. Think about fragment reattachment. If they come in, it's a lovely clean fragment, you can easily, relocate it. Think about reattaching that fragment. And if you haven't got time on that day to do it, book them in the next day. It doesn't matter if there's a slight delay in reattaching. And if the tooth isn't really painful or sensitive, then you don't even need to put a glass ionomer bandage on there, because the minute you put a glass ionomer bandage on, you have to remove it. And if you leave even a micron of glass ionomer on the tooth, then your fragment will not fit perfectly back into position. So again, as I said at the very beginning, you will have a compromised lute, and your fragment will fall off, and you'll start to think, a bit like resin bonded bridges, you'll start to think, no, it's not good. It doesn't work. That technique does not work. But it's not actually the technique that doesn't work. It's tiny little errors that maybe prevent you from getting a more successful outcome. So the uncomplicated crown fracture with the fracture injuries, with the luxation injuries, we saw large number of lateral luxation injuries. Yeah. I think that extrusion is easy and avulsion is easy. You just put the tooth back and it goes effortlessly back into position, and you just watch winding motion movement with apical pressure, push that tooth back up into its socket and then splint. The lateral luxation, and it took me a few patients before I worked out the key to success with lateral luxation. With a lateral luxation, the crown goes palatal, the apex of the tooth goes labial, and you get a dental-alveolar fracture on the labial aspect. The apex of the tooth nips in front of that fractured alveolus, and if you try and move the crown, it's locked in position. It will not move. It's not like an extrusion that's wafting in the wind. With the lateral luxation, the tooth is locked in position. So I tried brute force to push the tooth back into position on a couple of cases. Wouldn't move. I then thought, well, I don't know what to do. I picked up forceps. Oh, I shudder. Never use forceps. But I picked up a set of forceps, and I even thought I was clever by using it was an upper anterior tooth, using lower forceps, lying the patient back and standing behind them as though, I could get better access and better vantage point to move that tooth labially. And after a lot of pulling and pushing, brute force labially, I sort of got the tooth back into the right position. But you don't need to worry anymore. One little trick or tip that will save you hours and hours of worry afterwards and half an hour of clinical time is when you have a lateral luxation and the tooth is locked in position, you anaesthetize labially and palatally. So whenever you're doing a repositioning, you have to anaesthetize all around the socket, so labial and palatal, and then put your finger high up in the sulcus where the apex of the tooth is, where it's nipped in front of the fractured alveolus, and apply pressure. So what you're doing is you're disengaging that apex, and then you can effortlessly then move the crown labially and back into position. I think I've got a video of that on the modules on under lateral luxation.
You're applying the pressure, pushing it down.
So
what direction are you applying the pressure?
So it doesn't matter. All you're doing is putting labial pressure wherever. I wouldn't worry about trying to push down. You don't need to do that. Your thumb or finger is much bigger than the apex of a tooth. So all you need to do is apply that pressure and then move, because by applying that pressure, you're moving that apex. So don't overthink it.
So you're applying the pressure with the finger of one hand and moving the tooth with the fingers of the other hand.
Correct.
Okay.
But as I said, there's a video. So you go into the modules and see the video if you're not signed up already.
Yeah, because I think there would still be some education out there promoting using forceps to help reposition in a lot of locations. It's just your reaction when you said forceps there. Sort of, I was thinking, well, this will be interesting. But I think that's a really, really good tip. Because
remember, to grab hold of a crown, especially one that's displaced out of position, so you haven't got the usual vantage point to actually get to it. Well, if you're extracting a tooth, you put the beaks right up into the sulcus, the gingival sulcus, and you get onto the root and you start to jiggle and, extract your tooth. The minute you touch the cementum on the tooth, and damage it, you are predisposing that tooth to external inflammatory cervical resorption. So there's already been a predisposition to that by the actual dental trauma itself. We don't want to exacerbate that or add insult to injury by using forceps and damaging the cementum on the root.
So you've now got the tooth or teeth into this beautiful position.
Yes.
How do you now splint these teeth? What do you use? What materials do you use? Just talk us through that, because you said in your words that you had the young girl case you were talking about who fell over with her finger in her back. She had the splint on twice and they both came off. And you said that mines won't come off. So talk us through your gold standard.
Okay, so gold standard is when you reposition a tooth, and it's not so important with lateral luxation because your socket hasn't really been expanded too much. Your tooth is quite securely in position. And all you do is ask the patient to bite together and it will hold that tooth in position. But imagine that it isn't, and it's an extruded tooth and it might, start to extrude back out of the socket whilst you're getting your bits and pieces ready. So you use a temporary splint first. And what I would recommend with a temporary splint is you reposition the teeth. I always ask the patients to bite together and say, how does that feel? And providing that they can get all their teeth together, I know I've got the tooth back in the right position. And then I get a sausage of composite. So I'm holding onto the tooth that I've just repositioned with my thumb, for example, get a sausage of composite and then put it onto the incisor ledges of the tooth that's been repositioned and at least one adjacent tooth. And then ask the nurse, quickly cure that sausage of composite. So that will then hold the tooth in position for you. And you can then take your radiograph to check that you're happy with the repositioning of the tooth. Yeah. You do your check radiograph. If you're not happy, just say it was an extruded tooth and you can see that the periodontal ligament is widened still around the tooth. So you can then pick that temporary composite splint off, apply more apical pressure, jiggling forces to bust past any blood clot, push the tooth back up towards the apical side of the socket, and then apply this sausage of composite onto the incisor ledges again. get your nurse to cure that temporary splint, and then take another radiograph. When you're happy, you leave the temporary splint there and you spot etch the teeth that you're going to include in your splint. And generally we say one uninjured tooth either side of the injured tooth or teeth. So if one central incisor is the tooth that's been repositioned there and needs to be splinted, then you apply the splint to the adjacent central and the adjacent lateral. So one uninjured tooth either side of the injured tooth or teeth. So spot etch, wash and dry. Apply your bond, unfilled resin, onto each of those etched surfaces and then fully cure each tooth. You then get your wire, and I would recommend while the temporary splint is in position, before you start etching, etc., to cut your wire to shape and size. Pick up your wire, and you've also prepared some composite balls. And I say you need big balls and small balls to do splinting. So the big balls are about 2 to 3 millimeters in diameter of composite, and the small balls are 1 to 2 millimeters of diameter. So you've etched and bonded your teeth. You then take the big balls and just put each big ball onto each of the etched and bonded teeth. You then pick up your wire and embed the wire onto those balls of composite. Tap it down with your flat plastic to make sure it's as close to the labial surfaces of the teeth as possible, because the more proud it is, the more it's going to irritate the patient's lip, and they won't like you for that. They might get ulcers, etc. And then get your nurse to do a quick partial cure just to set those big balls with the wire embedded in it, just to hold it in position. You then get the small balls and put each small ball, and I used to use a finger and just pat it down because you want a nice smooth surface. Pat down the small ball, pick up the other small ball, put it down, pat it down with your finger. So what you're doing is you're enveloping the wire within composite. And then it's a full cure for each tooth. And then you take the temporary splint off, ask the patients to bite together. And usually they say, yeah, I can bring all my teeth together. Or if they haven't been able to bite together for 2 days, I had one patient couldn't bring her teeth together for 2 weeks. They'll say things like, I cannot believe it. Or, oh my God, and you'll hear this in the videos that you watch with the modules.
What wires are you using then? Because there's different types of wires for different cases, right?
Yeah. So there's two main types of wire. In hospitals for pediatric cases, the titanium trauma splint is brilliant. Brilliant. Don't write it down, Umair. Don't buy it. It's very expensive. Very expensive. But it's really good, really, really good, because the way it was designed was that it's malleable. So you can attach it to one tooth. Imagine in children, they've got mixed dentition stage and the teeth are all hickledy-pickledy, gaps everywhere, deciduous teeth and then adult teeth, etc. So you could use your flat plastic and just mold it like this and adapt it to the teeth as you go along and apply the composite cure. Next one, apply the composite cure. And the way they envisaged that you would remove it is 2 weeks later, 4 weeks later, whatever the splinting time was, you unpick one of those ends and then you pull, pop, 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 and you pop this wire off and debond the composite that way. I don't like that. One, because, you've got traumatized, you've got fragile feeling teeth. You don't want someone putting pressure on them at that stage. And the second thing is, I used it for 2 adult patients and the splints came off prematurely. They didn't last the normal time. So the alternative, I would say the titanium trauma splint is really for pediatric units where they really need something that is malleable, that they can adapt to a mixed dentition stage type of patient. For adults and for most cases, cheap as chips, so the titanium trauma splint, I can't remember how much it is, but say it's £35 for one strip.
Oh, it's more.
No, for
it's
one
almost...
strip. You can buy packs of 10 and it's £450 or something, so it is very expensive. The recommended splinting wire from the IDT is 0.16-inch orthodontic stainless steel wire, and you get packs of 100 for the same £35. Yep. So I would say, and those are available in any practice that does even a little bit of orthodontics, they will have those wires. So it's 0.16-inch, round, stainless steel orthodontic wire. And if you need to bend them, generally, if you buy them pre-arched, these packs of 100 pre-arched, you don't need to do much bending. But if you do need to do any bending, you cut to the size that you think you need. Then you can just use Adam's pliers to apply a couple of kinks here and there to get it better adapted to the labial surfaces of the teeth.
What about solder wire?
Okay, so I think solder wire comes in lots of different thicknesses and therefore different flexibility. I think if you've got no opportunity, say you're somewhere in the middle of a forge and somebody avulses a tooth and you need to treat them there and the only wire you have is solder wire, I would say it's better than nothing if it's going to hold it there. Even if it's used just as a temporary measure, then it's better than nothing. But why use anything other than the orthodontic stainless steel 0.16-inch wire? Because it's cheap, it's easy to use. In 2020, the IDT updated their guidelines and they went from a slightly thicker wire to this one. And personally, I think that this one for adults is too flexible. But that's the guidance.
That's great. So that's give us a great insight. What we have realized over the last hour, Serpil, is your extensive knowledge in dental trauma. I think that comes across in abundance. So I would suggest to all the listeners out there that if they haven't looked at Dental Trauma UK, to get on it and have a look at it. And for £30 a year, I think it's a steal for what you're getting out of it.
But it's free for your members, so...
Oh, it's free for our members, yes.
Yes,
but
we do. They're not paying £30.
No, they're not paying £30. But we do have a lot of international members. International members are allowed to join as well, aren't they?
And they will get free access as well.
Yeah.
Yes.
Yeah, so it's great. Get on the Dental Trauma UK website, have a look at it, become a member, either through the UK Sports Dentistry Association or independently, and get looking at the resources and get promoting the campaign. Selfie Your Smile. It's a great campaign to get behind.
Yeah, and I'll send out any of the material that we have when it's ready to you all so that you can share it. And I don't know what handles and hashtags are, but that's Umer's.
Don't ask me either. That's
exactly.
Umer's side of things.
Exactly. That my campaign manager, Frances, she knows what these things are, and she says to me that if everyone uses I don't know what they're called, handles. If they use them, then we can track how many people and where it's being spread and things like that. So yeah, I'll send you all the information as soon as it's ready. It'll be any week now, really. So we're nearly there with it. So please all share and help us.
Yeah, definitely. So we'll do whatever we can on this platform, certainly as time goes on, just to help plug Dental Trauma UK and the Selfie Smile. Once that is launched, you just let us know. Anything you need from John and I, we'll more than happy to help. And that takes us on to quite nicely to the UK Sports Dentistry second conference, which is in Manchester. So we want people to come and join, become members. They will then be able to join Dental Trauma UK as part of that as well. So we're very much looking forward to the next few months and the build up and the lead up to that. But we would happily help you, because I think if we can take Dental Trauma UK worldwide, which is what we want this platform to be able to have people from all over the world join and have access to that information, and to be able to watch your lovely videos and everything that you've done in the master of her trade, then we'd be more than happy to help.
Thank you so much, guys. Thank you, John. Thank you, Mayor. That's brilliant. And thank you, everyone who's listening.
Thanks so much for being a guest today. It's been really enjoyable. Have a great conversation.
Thank you.
Yeah, I've loved it, Serpil. Thank you so much.
Thanks.
We are delighted to have Ionate as a sponsor for the Sports Dentistry podcast. Are you looking for a water bottle that's built to keep up with your active lifestyle? Look no further than Ionate, the totally leak-proof water bottles with triple lock technology to prevent spills no matter where you're headed. With a simple one-touch opening mechanism, you can sip on the go without hassle. Plus, Ionate's sleek, modern designs are not only functional but can be personalized just for you. Made from high-quality steel, these bottles are easy to clean, and best of all, they're sustainable. From 320ml to 1200ml, Ionate has the perfect size for you. whether you're just out for a jog or going on a long hike. And it doesn't stop at water bottles. Ionate also has travel mugs and flasks to keep your drinks just right wherever you are. Ionate is the official water bottle supplier to the British and Irish Lions on their tour to Australia this summer, and are the official water bottle supplier to the NFL, so you know you're getting the best. I have been using their bottles for a long time now and cannot recommend them highly enough. So head over to www.ionate.co.uk to get your hands on the best bottles in the business, bar none. Now back to the pod.
Well, that was a great conversation we had with Serpil. You can just hear, we talked about it just before, about our guests having a real passion for what they do, and you can hear it in her voice, and then you can just see how knowledgeable she is when it comes to dental trauma.
I knew she was going to be fantastic to listen to, but she exceeded my expectations. Honestly, just her knowledge of dental trauma and her experience to get into that point and kind of taking it upon herself to now be at the forefront of Dental Trauma UK. I know she's retired now, but just the nuggets of information that she supplied there with regards to kind of pulpotomies and repositioning, that's the sort of things that listeners want to listen to, what the general practitioners want to listen to, because they can take that information now when they listen to it. And if they get a trauma case tomorrow or the same day they've listened to, they know exactly what to do. Yes, there's still more information they need to read upon and look at Andreessen and the IEDT and dental trauma website, everything like that. But see that those little nuggets there, like that's ingrained in my head now. So hopefully other people listening to it will feel the same way that I'm feeling. Like I'm feeling a bit of a buzz about, you don't want dental trauma to happen. Certainly don't. But if it does happen, you can feel more confident in dealing with it.
Yeah, definitely. And I just love that Selfie Your Smile campaign. I just think that is a fantastic. It's almost as ingenious as the wristbands for getting in and out of the hotel, but it's close.
Definitely game changer is what you call it, right?
Game changers. Yeah.
Exactly. And I think it will be, and I think it will be a game changer because, you know, she said they're going to release it later on in the summer, and we need to get behind that, and we will certainly help Serpil and Dental Trauma UK get the information and the education out there as much as we can.
Yeah, it's absolutely brilliant. So, like, if you're not already involved with Dental Trauma UK, I don't think there's any reason. If you're involved in sports dentistry, or even if you think you're going to have to help out with dental trauma cases, there's absolutely no reason at all not to be involved with Dental Trauma UK. If you're a member of the UK Sports Dentistry Association, you get it as part of your membership. But if you're not, it's only £30 a year, and for all that information you can get and all that guidance that you can get from being a member, and as you said, you're able to get access to the International Trauma Guide as well, which is really, really useful. And I think that's important to point out. Whenever I first started getting into trauma was back when I did the postgrad certificate course in Eastman along with Dave Connady, your colleague in Scotland, and I was having a conversation with Dave and another dentist down in Brighton, Patrick Nair. I probably didn't pronounce his surname right, like most pronunciations, but I was quite young. I was sort of saying, you know, there was quite a lot of information, learning about the different fractures, learning about the different luxations, and I was like, you know, you maybe don't see trauma a lot. You mightn't have a lot of cases every year, so it's not as if you're doing it every day unless you're in a setup like Serpil sort of described where you're seeing it on a daily basis. If you're not seeing it on a daily basis, it can be a wee bit overwhelming trying to remember everything. But Patrick had said to me, I just keep, at that stage, it was probably before the Dental Trauma Guide, but it was also a book it was like almost like a picture book, easy guide, trauma easy guide from Andreessen had wrote a book, and he says, I have that in my surgery, and anytime somebody comes in, I just refer back to it. And that, to me, that was like a more experienced dentist saying to me, you don't need to know everything, but as long as you know how to go refer back and look back to make sure that you have the right knowledge for helping out. And I thought that was great advice. So it's not necessarily, don't be feeling overwhelmed if you start to doing dental trauma the first time and having to know exactly what to do for every type of fracture, exactly what to do for every type of luxation. Just know where you can get that information. where you can refer back to that information. And don't be afraid to ask your colleagues as well. Another example of that is last I was involved with a really quite extensive trauma injury with an international athlete where there was two avulsions of the teeth, the upper right lateral and the upper right canine, and the upper right first premolar had been luxated. And I was a little bit unsure, especially because he was just about to travel away and go on tour for 2 to 3 weeks, and I was really trying to work out what was the best length of time, given what we didn't have access to him for this period. What was the best length of time that we could leave the splint on? What was the best options we could do for the avulsed teeth to try to make sure that we can keep them long term to try to prevent resorption and stuff? And I reached out to two colleagues that were more experienced than me. One was a colleague in America, one was a colleague in the UK, and I got their advice, and that helped me then put my treatment plan together to provide support for that athlete. So if you are just getting into dental trauma UK, or first getting into dental trauma, don't be feeling overwhelmed. You can use the likes of Dental Trauma UK to get that education, as long as you know how to refer back to get that. And also don't be afraid to reach out to your colleagues as well to get advice as well. Then they're there for your support, and that's the great thing about Dental Trauma UK and also the UK Sports Dentistry Association that we're building, that them friendships that we can reach out for scenarios where we need that little bit of reassurance and a wee bit of advice.
Yeah, I think you're right. And what Serpil said was you've got time. So she was like, when I've got the topical on, I'm talking to the patient, I'm getting a history, you start to understand what's going on. Even if you're unsure about what treatment you're going to do, you can still get local anaesthetic in. You still get local anaesthetic, you get that working. And obviously in the UK, we've got the WhatsApp group where we can easily, somebody could just put in there, I've got a patient come in, just a two or three lines, or even a voice note to say, I've got this trauma coming out, I'm unsure what to do, has anybody got any advice? And there'll be people on that WhatsApp, they'll be like, yeah, maybe you can do this, maybe you can do that. If you're struggling for time and just getting that information, that's the whole point about having this network, is that you can ask other people, because they may have been in exactly the same situation that you now find yourself in, but also having a quick guide to refer back to. So you've got something in the surgery, or you can bookmark the Dental Trauma UK website link in your Chrome or Safari, whatever it is you're using. So yes, having information at hand, but also being able to send a quick voice note or a quick message in a WhatsApp group and getting advice from other clinicians is absolutely key for not just success, but also in your own self-confidence about growing with regards to treating dental trauma.
Yeah, definitely. And it's that network and that support really helps. And at the end of the day, it's what's doing best for that athlete, or doing best for that patient. So don't be afraid to reach out to people or accept that you need to relook over something because you haven't had a case like that in a while. There's nothing wrong with that.
Not at all. And, like I say, it's a school day every day. We're learning new things all the time. Not every case is the same. There's always some variance. There could be a medical compromised patient as well that bisphosphonates. It opens up a totally different world. So you can never feel like you know everything, because you certainly don't. But if you can pass on your advice and wisdom and experiences to other clinicians, and this isn't just for sports dentists, this is obviously for your general dental practitioner, because trauma can happen anytime, anywhere. So this really is an episode for anybody out there who is a general practitioner in any practice, private practice, NHS practice, community setup, hospital setup, whatever. This will appeal to everybody.
Definitely. So that's another podcast in the books. And we're getting professionals to this. Umar, I'm getting there. It's almost the 10th podcast, is it? I'm sort of almost. So
almost.
I need to be on it. I need to be on it for number 10. That's what I said to say that.
No, mate. No, I think you're putting in a good effort. I know you're trying to practice my name every day when you're speaking to the missus. You call them the wrong name sometimes, and she's thinking, "What?"
I wouldn't go that far.
Nothing's too far for you, my friend.
Nothing. Have you anything on this week?
Yeah, I'm actually covering the Scotland-Ireland Women's Six Nation next Saturday. So looking forward to that. That should be a good game. And
Yeah, it should be
yeah.
interesting. I think England and France are quite strong. They've been quite strong in that Six Nations, and I think they're playing off now for who wins it. But probably Scotland and Ireland are very similar then underneath, and it'll be interesting as well, especially with the World Cup this year. So it'll be a nice way to finish the Six Nations for them.
What have you got on this week?
Not a lot this week. Just back in the clinic after Easter, getting back into it. I have a few scans. I have to go into one of the rugby teams to do a bit of scanning. That's about it. Hopefully a nice quiet week.
Good man. I certainly need a quiet week.
So until the next time, Boomer.
Yep.
Got it right that time.
There you go. There's my guy.
Right. See you next time.
See you, buddy.